There is still another student who has to take the exam, so I'd appreciate you not. They do take, if you don't take the exam on the same day that I give it, you do get a different exam, but there are still probably about 60% of the questions that are pretty closely the same. So please don't discuss the test until after Monday. What else? I have this note from the office. Yes.
You have like the 10% reduction?
Yes, there's a 10% reduction. Yeah. So it's, if you would have had a 95, you end up with an 85. It's the 10% is deducted from your score, the whole 10%. So it's not really worth your while. But if you can't take it at all on the test day, you're better off taking it with 10% deduction than getting no grade at all. Okay, some of you are still delinquent in getting paperwork to the office. Linda, you're still on the list. Did you turn it in? There's physical. For Maria Bermudez, you still have a couple of things. Certificate of insurance. They have that.
Well, they should.
Okay.
I do owe them my Hep C report.
Hep B titer.
Or Hep B, getting on Hep C, I don't have Hep C.
Okay. And then, Jude Choi? Yeah, you still need insurance, your CPR card, your chest x-ray, your physical, the Hep B titer, and MMR. Oh, you did?
Different CPR.
Congratulations. Good for you. This is yesterday, so if you did turn it in yesterday. And then, Kayleen Ireland. Where are you? MMR titer and Tdap proof. And then, Porfirio Palafox, Hep B titer. Where are you? There you are. Hep B titer. Okay. They've been pretty lenient this semester because normally you can't come to clinical without all the paperwork being done, so I suspect they're going to clamp down pretty quickly that you will not come to clinical if all your paperwork's not in. But it sounds like most of you have been following through on that and trying to get it in, so perfect. One more thing. Can I move these recorders, phones, whatever? Yes? I need to get to this box, this bag. Okay, I need to give each of you clickers. And pretty soon you'll see pictures on the screen, questions on the screen. All of you have clickers, and you can answer the questions, and we'll see how well the entire class responds to questions. So, there are, I think, 5 repeating students. So those who are repeating the course, you don't get one because you already have one. So I will be sending this clicker contract to you. If you should drop from the program or leave for any reason at all, you need to turn the clicker back in or we will do something to you. I'm not sure what it is. I will hold this place on your school records. I'm going to turn it back in. So you need to sign that, and then I will collect those. And then you get extras at the back of the room if you'll send them on over. Don't have any to give it. Extra here. All right. Okay. Anybody else has one? Got one? You don't need one. Okay, then, as soon as you sign it, how am I going to do this? If you bring me your signed contract, I will hand you a clicker and instructions on how to use it. In exchange for this, you get this and this. This, and this. You give me yours, I give you this, and a clicker. They're not calculators, they're clickers. There. Oh, I didn't count how many of these I had. And I will make some more copies. I can give you the clicker, but not the instruction sheet. I can bring those. How about if we do that? Then everybody gets their clickers. I'll make more instruction sheets. I ran out of instruction sheets, but I'll bring them to the class next time.
That's what the lady thing for
No, I have to make some more.
Oh, this is the lady's part. I want to write it down. Oh, thank you.
I counted the contracts, but not the instruction sheets. Oh, here. I know I ran out. Hold on.
Are you recording?
I have 3 more instructions.
Hello.
You didn't get your clicker yet? No. Instruction sheet. Instructions.
Thank you.
And I ran out of instructions, but I'll bring some more.
Professor, can I move this back?
Sure. Okay, back to the lecture. All right, continuing with Module 3. I'll try to post we have a week to post the exam. I usually try to do it sooner than that, but I try to do it when all the tests are in. I don't have to do that whole setup twice, so probably, I'm guessing, I might come in after clinical on Tuesday or Wednesday. Yes.
Back from Rowena, our friend.
Oh, I talked to Rowena today, and she did not have a chance to look at them. She's going to drop them off at my house on Sunday, so I can give them to you on Monday.
Oh.
That's the deal. The prep tool is due on Monday. Yeah. So that wouldn't help a whole lot, huh? But you would have the advance, the opportunity to start correcting whatever, right, on your prep tool, instead of waiting another week. Yeah. You will already have the revisions for your prep tool to start working on, because everybody's turning them in on Monday, right?
Oh, I'm not following. It's due Monday.
It's due on Monday. You want a feedback prior to Monday. I understand that.
Yeah.
But even though you didn't get it back today, you can start working on revising if there's any revision needed, whereas everybody else who turns it in for the first time on Monday, they won't get it back until a week later. But you can have that interim to fix it. Yeah. Okay, continuing with the immune system. Back to the test. I posted on Blackboard. You know that. Okay, good. All right. Immunologic changes in the older adult. Lots of changes everywhere. If I don't trip and fall on my lines here. Okay, we already know about the decreased immune system function. What do you remember about the immune system? What's decreased? What in particular do you remember? The what? White blood cells decrease, and if they have an infection, they do not develop leukocytosis. Do not. Okay? So leukocytosis is high or low white blood cells? High. So they do not develop leukocytosis, and fever generally doesn't occur either, whereas younger adults, you would get a fever if you had a huge UTI, you would not feel very well, you'd have a high white count. Doesn't happen in older adults. And not even during an episode of very acute infection, and that's why we get those patients who come in with urosepsis. They didn't know they had a urinary tract infection. They have it long enough where the organism ends up in the bloodstream, which is urosepsis, and then they're really sick. The mortality rate of urosepsis is fairly significant. Also, if you give them a TB skin test, you think it's positive falsely or negative falsely? It's falsely negative, yeah. They have, just in general, very much lowered resistance to infection, and then I listed some of the most common infections on there. They have a high risk for both bacterial and fungal infections. Those are the most common infections we see in older adults. So the most common ones, bacterial pneumonia, the UTI and the urosepsis, gram-negative bacteremia, infected decubitus ulcers. Once they get a decubitus ulcer and that barrier that the skin provides is lost, they'll end up with decubitus ulcers that readily get infected. Intra-abdominal infections, very common, the pancreatitis, the colitis, the gastritis. We'll see patients come in with. They have a poor response to immunizations, but we do have to focus on making sure they get their flu shot. And what else should they have? The pneumonia vaccine, absolutely. And then they also have frequently reactivation of diseases that they have had before, particularly viral diseases. Which one is the most common that we see? Shingles. And shingles is in response to what disease did they have? Chicken pox. Okay. And we're still looking at our older population now that still had chicken pox. It was well before the vaccine was being administered. So when they get stressed, that vaccine is kind of like a cold sore. It stays in your system and then it just erupts when you get physically stressed, emotionally stressed, or in response to perhaps surgery. And so then those disease processes are reactivated. So instead of getting chicken pox, they end up with a very painful disease called shingles. There is a vaccine for shingles as well. Just in general, I'm going to look at a lot of these, the list of selected health problems. In terms of health problems, I think we know and are familiar with a lot of these, so we'll take a look at specific ones. So what kind of, do you have a slide that says healthcare issues in hospitals next? Or not yet? I think mine's out of order. Okay, so health problems of the older adult. Many older adults. How many of your patients had hypertension and are getting medications for hypertension? So very common. High percentage, almost half. And then it has a whole list of things in declining order that we commonly see in older adults. And I've never figured out why sinusitis is in there, but it was on that list. The average 75-year-old has 3 chronic conditions and takes 5 prescription drugs, so that's pretty significant. But I know some of you have seen some of your prep tools. You have 30 meds. That's a lot of meds. Okay, chronic disabling illnesses, more than half of all older adults report at least one disability. And here's discrepancy in numbers here. 90% of adults are functionally independent up until an average age of 92 years. So if you live to be in your 90s, past your 80s and start into the 90s, chances are if you actually make it to almost 90, you are statistically most likely to be independent. But then the statistic at the bottom doesn't make sense to me, that 50% of 90-year-olds need long-term care. So maybe they need long-term care, but they don't get it. Maybe they're still at home, they truly need 24-hour support, but they hang in there and they try to maintain some sort of independence by having people come in, family members, neighbors, and that sort of thing. So if they have a disabling condition, many have a need for assistance with ADLs, the dressing, the grooming, the bathing. So if they are not at home, people who need assistance with ADLs, where would they end up? Probably in assisted living, if all they need is just help with that. They just need someone to help them with the dressing in the morning, taking a shower, and perhaps they can't cook their own meals. May result in role changes. What role changes occur?
The kids are taking care of the parents.
Yeah, instead of being the parent, the children now are the parenting the older parent, absolutely. Only 4.5% of older adults end up in a nursing home. So that's really good news, because how many are not in the nursing home? 95.5%, right? Not in a nursing home. Many families do end up helping to care for older adults when they get to be in their 90s, but it's nice to know only 4.5% end up in a nursing home. Small number. Does anybody have any idea what a nursing home costs here in Southern California? Lots, but how much do you think it costs? $6,000 to $7,000 a month is average. So it's $7,000 a month. That's $84,000 a year. It is very expensive. Medicare does not cover nursing home care. Did you know that? Does not. So if someone ends up in the nursing home and they can't self-pay, Medicare pays, I think, X number of days. So if you're in an acute care hospital and then you get transferred to like acute rehab, like we've seen some of our patients, then Medicare pays X number of days. If you don't have the opportunity to get well enough to leave the facility, they put you on what they call Medi-Medi, Medi-Cal Medicare. So it's entirely government funded at that point in time. And Medi-Cal Medicare pays very little in terms of what the actual cost is of nursing homes. So many nursing homes will not accept the Medi-Medi patients. They want either self-pay or they'll take that short time that Medicare does pay. So there are many places that will not accept the totally, what should I call them, indigent patients who can't pay any component of their care. And then you end up in those nursing homes that you come in the door and you think, oh my gosh, right? They smell bad, the care is very minimal. So we're not in those kind of facilities with students. So if you think it's bad where you are, there are places that just make your heart sick to see that people are warehoused in that sort of a situation. It's pretty sad. Okay, another health problem we're going to take a look at is drug use and misuse. Older adults consume more drugs than any other age group. They rack up 25% of all drug costs, and 30% of all prescriptions written are for seniors. Many take over-the-counter drugs as well. So not only do they have 13 prescriptions a year, they also take over-the-counter meds, often having a conflict in terms of the effects of meds that we need to be very careful with. The term with older adults, polypharmacy, you'll see it in articles, you'll see it in your textbooks. Polypharmacy just means that they have multiple drug use in terms of prescription drugs and over-the-counter drugs. It is getting much better than it used to be. People used to have, and probably still have, multiple physicians. And then they would go to 6 different pharmacies. And one doctor prescribed Lasix, and the other doctor prescribed furosemide, not knowing that they already had, and it's the same drug. May still be happening, but now with computers and cross connections and people trying to get their prescriptions filled with a new Medicare prescription plan, it's much more manageable in terms of somebody reviewing if they have multiple drugs as well as drugs that are interacting negatively with one another. Okay, so it results in medication duplication, adverse drug interactions, use of contraindicated drugs, use of drugs that are no longer effective. I have seen a number of people over the years who had just that long list of 20 meds and just having all kinds of issues, not really getting well. You couldn't really tell that the meds worked, and they would back them off one at a time. And I've seen families do this too. Just remove one, and then after that drug has been tapered off, they'll take them off of the next drug. And surprisingly, there are a number of people who significantly improve when they don't have all those drugs to take. I know a family from church, and the gentleman has Parkinson's, along with Parkinson's-associated dementia. And he had been prescribed new medications, and the wife was saying, you know what, all of these meds, I can't tell that anything's getting better. And she says, so I'm backing off on all the meds. And I said, what do you mean? She says, well, if it's 3 times a day, I'm going to give it twice. If it's 4 times a day, I'm going to give it 3 times. And next week, I'm going to reduce it by another pill. I talked to her recently, and she said I took him off of everything. He's now awake. He's responsive. He is familiar with people in his environment. He was so confused and unparticipative and was just not really participating in life at all. So I'm not saying that's a good idea for everyone, but occasionally all those meds have this cumulative effect and don't seem to make a big difference. And sometimes just a couple of drugs might be all they need. Okay, this particular slide, aging and the effects of drugs, is an important slide. So you may want to highlight it. It's really important because of the physiologic changes that occur with aging. So drug absorption in older adults, it is complete. It is not incomplete, it is complete, but the drug absorption is a great deal slower. So if you have a patient, because physiologically the liver functions less effectively, I think the liver is at 50%, the kidneys are not as effective, they've lost function over the years. So if in addition then to those normal changes due to aging, you also have heart failure. How does that reduce the rate of drug absorption? If you have heart failure on top of all the normal physiologic changes, what happens?
Reduces the rate of absorption.
It reduces, but how?
Blood absorption.
The blood flow is what promotes absorption, right? So if you have heart failure, is your blood flow to all parts of your body effective? No, it's not. So with heart failure, there is an even greater reduced rate of absorption. There's decreased lean body mass. As we age, we lose muscle. I think it was yesterday I mentioned how much muscle we lose after the age of, I don't know if it was 30 or 50, but it's significant. And in almost all cases, when you lose muscle, it's replaced with fat. Muscle weighs more than fat. So even if you retain the same weight, you may have lost a lot of muscle. So to maintain the same weight over time, they gain weight. But they have, if you were to reduce the amount of fat that they've gained that replaced the muscle, they would have intentionally sort of lost, in essence, would have lost weight had it not been for the fat that replaced the muscle mass. So with decreased lean body mass or muscle, there's increased adipose or fat tissue. So as a result of that, water-soluble drugs can reach toxic levels really quick because there is less water in the entire body. The percentage of water is diminished from what a younger adult would have. And then fat-soluble drugs are absorbed less well because there's less vascularization of fat stores. Fat doesn't have as much vascular perfusion as muscle has. So it takes longer to reach therapeutic levels, and it takes even longer to excrete the drug. So that's why older adults become toxic so quickly. Then you add to that, the kidneys generally excrete, the liver detoxifies the meds, right? And then the kidneys excrete the residual, I don't know, what should I call that? So renal perfusion, you need to very carefully monitor drugs that are nephrotoxic. Many antimicrobials, the oral hypoglycemics, even NSAIDs, and cardiac drugs can be very toxic to the kidney. When antimicrobials, especially the not the hypoglycemic drugs, what are the ones that are so nephrotoxic? Aminoglycosides. So in many hospitals, before we give them aminoglycosides, they check to see what kind of renal function they have, and in addition, they require a hearing test. In many hospitals, that's standard because it's not only nephrotoxic, but also ototoxic. So if you wonder why they're getting that sort of test before they give the meds, it's because the drugs are so nephrotoxic. Then add to that the protein malnutrition and the inability for the drug to be absorbed and to be effective. So if they have protein malnutrition, the prealbumin is less than 15 and the albumin is less than 3.2. I think I said if it's 2.5, at 2.5 they have severe malnutrition, but they try to treat it on patients when it's still in the 3s so that they never get to the 2.5. Okay, so if they have protein malnutrition, they have fewer protein binding sites for protein binding drugs such as Coumadin and Dilantin, and they have more free drug to circulate and puts them at risk for bleeding or confusion for those two drugs, the Coumadin and the Dilantin. So we try to go with the rule of 3s. Try to not prescribe more than 3 drugs because more than 3 can be dangerous, but all of you have patients who probably have much more than 3, right? So it's hard to stick by that. And to start with the dose really low and go slow before you start adding doses. Okay, some of the drugs that are responsible for adverse drug reactions and hospitalization, let's start with the analgesics. Why do those cause hospitalization due to toxic reactions? Name some analgesics. The what? Tylenol, did you say? Yes, can have toxic effects mostly on the liver, can cause liver failure quickly. Analgesics, like patients who are getting pain meds. Dilaudid, what else? The morphine, the Demerol, the oxycodone, the OxyContin, the oxycodone, all of those meds. What do they cause? What would bring them to the hospital? Drowsiness. Family members will say, you know, he doesn't wake up anymore. Or I can't wake him up enough to eat. What else? Constipation. And it gets so bad where they come in because they have what? I know, but what do they end up having? A bowel obstruction. Yes, very common. Aspirin, why are we concerned about aspirin? Bleeding. And if they complain of tinnitus or ringing in the ears, what does that signal? Toxicity, toxic dose of aspirin. Chemo, why do patients who are getting chemo come into the hospital? GI what? Bleed? Probably not GI bleeds. GI associated problems, absolutely. Like what? They have tremendous nausea. If they're bleeding, they would have blood in the stool in the GI system. Possible, but not as common as the nausea, the vomiting, and the sores in their mouth, those mouth sores that make them, makes it real difficult to swallow. So that's why they would come in if they're getting outpatient chemo. And it's mostly nutrition related because they can't eat. Whatever they eat, they throw up, or they have no appetite, or they have such tremendous problem with their oral, those oral sores that they get. What's that called? Stomatitis, yes. And they just can't, it's in their throat, they just can't even swallow. So nutritionally, they're getting nothing. How about DIGE? Causes dysrhythmias. What else does DIGE cause? So they'll come in saying, my heart feels like it's pounding. So they'll have palpitations. It also causes depression. Okay, the next one, antidepressants. Wonderful drugs in many cases, but it causes a lack of appetite. So the nutrition is affected. Anorexia, tremendous weight loss, as well as sedation. Can't wake them up. Okay, the next one is insulin. If they are newly diagnosed type 2 diabetic and they're taking insulin, what do you think they come in with? Low sugar. What's that called? They come in with hypoglycemia. Okay. And sometimes the blood sugar is so low that they're unconscious. They're not even responsive anymore. A lot of them get prednisone. They have joint problems, so they're taking systemic prednisone, corticosteroids. So why are they coming into the hospital? Weight gain, hyperglycemia, the fluid overload, hypernatremia because they have such large volume of overload. And what else do these, the prednisone, the corticosteroids, what do they cause? Tremendous problem with, causes with the bones. Osteoporosis, yes. And then we have lots of people take diuretics. Oh, theophylline is next. Why theophylline? What are they going to complain of? A racing heart? Okay. How about warfarin, the Coumadin? Yes. It's monitored very carefully, but you know how the drug absorption, we just talked about the absorption and the excretion, and so these patients will come in with bleeding. What are you going to teach those patients who are on warfarin? What should they report to you? Bruising. Bleeding gums, yes, when they brush their teeth, and if their gums are bleeding, that's a pretty good indicator that they may have a pretty high level of Coumadin on board. What else? Yeah, don't use a safety razor, always use an electric razor. It goes for you as well. If your patient's on Coumadin, do not use safety razors when you shave your male patients. What else? Anything else about the Coumadin? Biggest problem is bleeding, okay? What labs do these patients, do you have to monitor if you give Coumadin? Okay, the PT and the INR. The PTT is for heparin, yes. And then those diuretics, what do they come in with?
Heart problem. Low potassium.
Could be. What else? Low blood pressure because they're becoming hypovolemic. They've lost so much volume, so they get dehydrated. Okay, and their potassium is low because they peed it all out. and we weren't monitoring the potassium perhaps as closely as we should have, or we probably were, and it happened anyways. And then patients have antibiotics. We see them coming in if they have aminoglycosides with renal failure. Acute renal failure, not the chronic, but often they have sort of chronic on top of acute. Okay, other problems that occur in older adults, and keep in mind many may have been drinking all their lives, but there's a higher percentage as they get older. It's associated, often the drinking may increase, and it's associated with those loss of spouse, loss of their independence, loss of their ability to drive, loss of, their home perhaps. Chronic drinking causes progressive liver and kidney damage. It damages the stomach, so they may come in with GI bleeds. Patients who are truly alcoholics, we call them frequent flyers. They come in very, very often with side effects of their alcoholic intake. Okay. If you ask on your initial patient assessment when they come in and you ask them, do you drink alcohol? We usually say that if they say yes, multiply it times 4. Because no one ever gives the honest amount of whatever alcohol they're drinking. So if they're drinking a 6-pack, then maybe they're drinking 4 6-packs, right? If they're saying they have 2 drinks a day, maybe they have 8. And you will know when they start having DTs. And it's like, you must have been drinking more than those 2 beers a day, right? Okay. But alcohol increases the effects of narcotics and anticoagulants. So it's kind of risky if you send them home with pain meds and they're drinking large amounts of alcohol. It decreases the effects of antibiotics, and the combination of drugs and alcohol can lead to very serious drug overdoses. I think we see that in people who are not seniors, but it's pretty more significantly, frequency is more significant in older adults because of the alcohol stays on board for so long as well. So what is your job as a nurse? You need to just advocate to the individual, the patient, to facilitate the treatment of the drinking problem. Often they don't see it as a problem, so there's nothing you can do. You can't be the alcohol prevention nurse any more than you can prevent someone from abusing pain meds. So don't stereotype or prejudice or show prejudice, but do review all the meds, the effects and the side effects that they have with alcohol. There are drugs that can be substituted that are not as significant in terms of their interaction with alcohol. So you can just maybe ask the physician if they could change some of those meds. So be supportive and offer help. The next major problem, many of you have already seen patients who have dementia. You may have family members who have dementia. Dementia is a general term that refers to a progressive condition, so it's progressively getting worse. That's manifested by multiple cognitive deficits that include memory impairment and at least one of the following that's listed here, amnesia. Amnesia is memory loss. It starts with loss of, what kind of memory is lost first? Short-term memory is most affected by dementia. They will still have, for a long period of time, their long-term memory. It's been cataloged in their brain and filed away for 60 to 80 years, or whatever their age is. They will have aphasia, speech impairment. They can't really come up with the words that they want. You may be their nurse and they'll say, give me that, would you give me that? And then you're looking at their tables like, well, give you what? Give me that. And they can't come up with the word. Maybe they want their, their cup of water. Maybe they want their glasses, but they can't come up with the name. So if they're pointing, they can still recognize that they need it, they just can't come up with the word. Anomia is the inability to name the objects that they want. So it's kind of like, give me this or give me that, or they'll call it something else. Give me those shoes, and what they want is their phone. Then they will have apraxia, and that's the inability to use objects or perform tasks. So they may pick up what's at the bedside. Their television remote, it's on a cord, often incorporates the nurse call system. They'll put it to their ear, and you wonder what they're doing, and they're trying to make a phone call, and then they get upset because nobody's answering the phone. They no longer know what the function is of the phone or the function of that remote that they have. Agnosia is inability to comprehend visual or auditory input. So we try not to have abstract pictures in their rooms if they have dementia. If they are in the room and the television is on and they get agitated, they can no longer discern that that television is make-believe. Make-believe in the sense that that's not occurring in their room. A lot of the news and things is not make-believe, certainly, but they don't know that that's a television. And so they only sense that this is happening in their room. Makes them very upset, very agitated. So maybe they could listen to some music or something instead of that television. Impaired judgment, problem solving, and impulses, very common, and then personality changes. So we're going to take a look at what the phases are and the types of dementia. There's primary dementia, and primary dementia is generally the Alzheimer's type, Alzheimer's disease. Most common, about 50 to 90% of dementia is Alzheimer's type of disease. There's also a type of dementia called multi-infarct dementia, and multi-infarct dementia are people who have microscopic little strokes, and they have many frequent little tiny itsy-bitsy strokes. And over time, all of that damage becomes progressive, and they start having all of these signs and symptoms of dementia, but the underlying cause is small strokes, occluded blood vessels in their brain. Another kind is Lewy body dementia, and the Lewy body dementia is frontal lobe dementia, and it's associated with people who have Parkinson's disease. Many who have Parkinson's also have dementia. The underlying physiologic cause is a little bit different. They also have, if they have Parkinson's and they have Lewy body dementia, those patients also have gait disturbance. Have you ever seen someone with Parkinson's try to walk? What kind of walk? They shuffle. So they can't pick up their feet anymore. And sometimes when it gets to where it's pretty progressed, they want to move, and you can see them trying to move their legs, and they're working really hard to move, and it's like they're glued to the floor. And then at some point, they'll actually start to move, and some of them, once they start to move, can't stop. So usually we have someone who ambulates with them, but it gets to where they can't move at all. They also have the tremors, can be managed with pain, with meds, yes?
The one thing you were just saying right now is that way you see the CNAs, they have the wrap around them and they're walking on them.
Oh, that's a gait belt. Not just for people who have dementia, but it's just to keep them safe and to prevent them from falling, and it gives you, the caregiver, a much better hold on them. And you can walk next to them, hold on to that belt. It's around their waist, so it's at their center of gravity, and you can control if they're, hopefully, if they're going to fall, you wouldn't be able to sit them down, but you have better control over their ability to stand up. And then their secondary or pseudo-dementia, not really dementia, but it's due to underlying disease processes. Those who've abused alcohol all their lives end up having what's called Korsakoff dementia. It's due to the brain damage from continuous saturation with alcohol over the years. Sometimes patients who have HIV develop dementia as well. Frequent head trauma, very high risk of causing dementia in later life. They've done some studies of those football players, boxers. They generally end up with dementia from repeated head injury, blows to the head. The Creutzfeldt-Jakob is mad cow disease in people. We occasionally, I've seen a couple in my nursing career, but they develop dementia too. These statistics are kind of scary. 50% of all nursing home residents have dementia. So I should see 50% of your hands go up. Did anybody have a diagnosis of dementia? Yeah, lots of you. 30% of the population over 80. What's the fastest growing group of seniors? 85 and older. So we're going to see tremendous explosion of people who have dementia, Alzheimer's disease. By 2015, there will be 14 million people in the U.S. with dementia. And Alzheimer's disease alone, I think it was in 2010, cost the taxpayer $90 billion a year. And that's for Alzheimer's disease. And again, Alzheimer's accounts for about 2/3 of all dementias, from 50 to 80, 90%. So what happens if you have, what's the pathophysiology of dementia? The pathophys of dementia is that there are microscopic changes in the brain tissue itself. It develops what's called neurofibrillary tangles, and there's a nice picture in your textbook that shows the neurons, the nerve tissue, getting just sort of tangled up like threads, just getting tangled up into each other, and it causes them to no longer be able to function. They also have a lot of plaque, and that degenerates the nerve terminals, so they can't communicate anymore. Those synapses are gone. And within that plaque, it consists of a lot of beta amyloid. It's an abnormal protein that's in the plaque that continually works at destroying brain nerve tissue. They also have granulovascular degeneration and a lot of chemical changes with dementia. There is a 75% loss of acetylcholine. And when you lose acetylcholine, you end up with a dysfunction of cognition. They can't function normally anymore. They have total loss of recent memory, and they are unable to acquire any new memories. So that's the patient. You come in, you say, "Good morning, I'm your nurse today. I'm a student from Santa Ana College." And the next time you see them 2 seconds later, "Who are you?" "Oh, I am so-and-so from Santa Ana College." You walk out of the room to get a towel to give them a bath. "Who are you?" They cannot build new memories. Okay? Does anybody know what the underlying cause of dementia is? No. A lot of research going on. The Alzheimer's Association has a lot of walks to develop, to raise funds for research. They think that genetics may have a major impact on whether or not you're going to have dementia. My mom died of Alzheimer's disease. She was a twin, and she had 7 siblings. There's one sibling, there are 4 siblings still alive, but one does not yet have dementia. She's the youngest. She's 84, I think. But every one of my mom's brothers and sisters is either dying of Alzheimer's or died of Alzheimer's. It's just the craziest thing, including her parents. So, environmental agents, they were thinking perhaps viruses. Aluminum toxicity was sort of the word a decade or so ago. They've decided that probably not. Immunologic changes, there's a lot of research going on. Nobody really knows for sure what causes it. We just know that many, many people have dementia, and as you age, the chances of getting it increase exponentially with your age. So the thought is that it's just like heart disease. When you drop dead of a heart attack, at whatever age, that process of your arteries having that atherosclerosis developing doesn't happen overnight. It doesn't happen like 30 days before you have your heart attack. Your blood vessels get pretty gummed up throughout your entire system, and then you have a heart attack. They think the same is happening with dementia. They have looked at the brains of young people who had multiple head injuries, who died for whatever reason, and then they looked at the brains and they were amazed at the state of progression that their dementia was in. But you can sort of fend it off when you're younger because you haven't lost that 3 to 7% of your brain weight yet, which you lose as you get older. And so as your brain reserve diminishes, it is much more likely that those signs and symptoms start appearing. Okay, according to the Alzheimer's Association, this is a little different than your book. There are 3 stages of Alzheimer's. The first stage lasts anywhere from 1 to 3 years. There's memory impairment, loss of judgment, and significant forgetfulness. It is at this stage where you have changes in mood and personality. People who were always easygoing may get angry about everything. They may have difficulty with where they're supposed to be. My mom always picked up my kids, and we didn't know she had dementia. It sort of creeps up on you. It's kind of like a child growing. You don't see it till you look at the pictures. And so if you're with someone every day, you don't realize the change that's occurring. So I would call my kids would call. There were no cell phones then. They'd call from school. They'd say, Grandma still isn't here. We waited an hour. She wasn't a real punctual person. So the kids are willing to wait an hour for Grandma to pick them up. And they'd call me at work and they'd say, we've been waiting, she's not here. I'd call my mom and I'd say, Mom, the kids are waiting. It's been an hour. Could you please go get them? Well, of course, I'm leaving right now. Had I known I was supposed to pick them up, I'd pick them up. Well, Mom, you pick them up every year, every day. Why not today? Well, like I said, if you remind, I'm leaving now. Okay, we'll find them. And that sort of went on, and every now and then, it wasn't like every day. But then it got more frequent. I was like, oh my gosh, how come you can't remember something you've done all these years to pick them up from school? She'd look at me like, well, hello? I left as soon as you called. All right then, but we still didn't know what was going on. But she just would forget that she was supposed to go to visit a friend or something. They had a little group of people, friends who would play cards once a week, and then she wouldn't show up. They'd call and say, oh, are you coming? Coming for what? Well, we play cards every Wednesday night. Oh, is today Wednesday? Oh, no, I'm not coming. You know, or they didn't call, and then the next week they'd ask, and they'd say, I wasn't here. She'd say, I didn't come. She didn't know. So people were starting to notice that there was something really odd going on with my mom. The withdrawal depression, because people know something's wrong. They know they can't remember, and they know when people remind them, like I would remind my mom to come get the kids, that, oh my gosh, aware enough that there is something wrong here. So that causes depression, withdrawal from doing those things that they normally did. Then the stage 2 can take anywhere from 2 to 10 years. I think your book says 2 to 3 years. Depends on how quickly the disease progresses. It's a progressive disease. Some people take longer than others to get to this stage. And the stage 2, there's more the severe cognitive impairment and disorientation. When my mom was sort of on the edge of stage 2, she was picking up the kids one day, and she stopped on the 57 freeway in the middle of traffic, and my kid said, so what are you doing? And she said, I don't know where I am, I don't know where I'm going, I don't know what to do. She had a bench seat in her car. My son was, I think, in 8th grade, 7th or 8th grade, and he said, move over, I will drive home. So she moved over, he jumped behind the wheel and drove home. And so at dinner time, the conversation was, Mom, did you hear what happened? No, how would I hear what happened? Grandma didn't tell you? No. I drove home. I said, what do you mean you drove home? Oh, yeah. She stopped in the middle of the 57 freeway and said, I don't know what I'm doing. So he said, I told her, move over, I'll drive you home. So, drove her home. Then, my dad would call, because she always dropped the kids off. By then, my husband was home from work, and she'd go straight home, because rush hour. And my dad would call and say, well, is Mom still there? I'd be home already. I'd been home, I was like 6:30, and I'd say, no, let me ask the kids what time she left. Because, you know, we didn't know what time she was picking them up. She was always late. So they'd say, oh, yeah, we were here by 3:30, 4 o'clock. She went straight home. We figured after the fact that she would get lost, didn't know where she was. She would sometimes then kind of, something would click, she'd see something familiar, and then could go home. And so my dad was saying, you know what, he always filled up her gas tank. She's using twice as much gas as she used to. I don't know where she goes after she leaves your house. We just didn't know. We figured if she was driving who knows where. But then one day she didn't come home. She was lost. And she stopped somewhere in tears and beside herself at a gas station, I think. And they called my dad, and he picked her up. And that's when we realized, oh my heavens, what is the problem here? So at that point, she was actually diagnosed with dementia. Before that, she was just doing stupid things that we didn't connect. So at this point, there's impaired and both recent and remote memory, anomia, agnosia, praxia, and aphasia. All of those, or some of those, occur. All cognitive functions are impaired. There's greater confusion about time and place. My mom walked out the front door, and she wasn't with anyone. She would not know how to go back. She didn't know that was the front door. So my dad had those deadbolts that you needed a key to open. So he would just lock the front door so she could still go in the yard, but she couldn't wander out into the street. Perceptual disturbance, so she would see things. She'd have these hallucinations, goodness sakes. There was a plane, this is years ago, there was a plane that had flown from Hawaii. It was one of the planes in Hawaii, and that whole fuselage had folded back years ago. But she said, she remembered it from the news, and she said, there was a plane that flew over, and the pilot was lost, and I talked to him, and I told him where LAX was. I said, how did you talk to him? Oh, he was hanging out the window, and I happened to be out in the yard, and so I gave him directions. We were thinking, what are you thinking here? Lots of impulse control, just lots of memory all around. If she had just eaten a meal, she wouldn't remember, so if you had food out still, she'd eat all the rest. If she was visiting someone and they put a plate of cookies out, she would eat the whole plate full and not have anything for anyone else, but she didn't know she'd already had a cookie or whatever they had, and so her friends at that point really weren't sure either. They said, what has gotten into her? She ate like 20 cookies and 10 bonbons, and nobody had anything else. She just kept eating. The anxiety, the wandering, the restlessness really drove my dad crazy because she wouldn't go to bed at night. She was sundowning. The sleep-wake cycle disturbance. She would be awake all night long. He had to take the knobs off of the stove and the what do you call the thing in the sink that holds the water in the plunger? No, whatever that's called, the stopper. He took all of those out because she would turn the faucets on and he couldn't stay up all night. So he just child-proofed the house, and she'd roam around, and in the morning he didn't know if he was going to find the milk under the bed or in the sink or in the freezer. She would stash stuff, take it out, move it everywhere else, and he never knew where anything was. Hyperorality, at this point she also started becoming incontinent, and that really was difficult for my dad. He came home one day, he would lock her in the house if he had to run an errand, thinking he had child-proofed it. She was afraid of the car. He came home and she had bowel incontinence, had put her hands in her pants, and so there she was at the table, and she was such a mess. My dad called me in tears, and he said, I don't know what to do, I don't know where to touch her, where she isn't full of poop, and I don't know where to start. You need to come over right now. So I came over to help, and she was so afraid of the shower. She came from Europe during World War II. They had all of those concentration camps and the gas chambers. So I was trying to yank her into the shower. She wouldn't go. They're going to kill me. Those are gas spigots. No, they're not, Mom. I'm going to wash you up. You're a mess. And then so finally I said, okay, I'll take a shower with you, because she was just such a mess. So I jumped in the shower with her, and she hugged me, and I kept thinking, ugh, don't touch me. And she said, at least we're going to die together. Now that we're in the gas chamber, we're just going to die together. I'm so glad we aren't separated. So I got her out of the shower, and she just jumped, and she said, get that woman out of here. What woman? She goes, that woman over there, I'm naked. So, what woman? She didn't recognize me or her in the mirror. She thought there were two other people in the room, and by golly, you better get them out of there, because I don't know who they are. So, like, oh my goodness, where are we going from here? She was diagnosed with Alzheimer's dementia when she was 60 years old. She died when she was 83. Had her for 23 years. And when she died, she could no longer, she hadn't spoken for a long time, was totally incontinent, was totally unaware that she was alive. So this is the stage 3 here, very, oh, it's time. Thank you for letting me know. I'm so sorry for holding you over. Thank you. All right, see you next week. See you on Monday. Yes, bring the clickers. Yes, and I'll bring the rest of you instructions.
You say multiple questions in case you change